I'm hoping, I noticed a few messages here that folks were not able to hear when we first put the screen live, but hopefully now that we've opened up the microphone, everybody can hear. Please let us know via chat. And at this point, I'd like to welcome Mike and say thank you for joining me today. Let me ask you first to give us a quick background on you and your experience in the industry, and a quick overview of what we mean by risk analysis and its relevance to meaningful use.
Well, thank you, Wendy, and thanks to everyone that's taking time to participate in this webinar today. My background goes back about 30 years in technology, and through part of my history, I was the CIO for a hospital right at the time that the HIPAA security rule was being implemented in 2005. And I've also worked for companies that have provided technical services to healthcare organizations, which has made me both a covered entity when I was working for the hospital and a business associate when I was working on my own with healthcare clients. So I've got experience with HIPAA audits and compliance going back to 2003, and have also worked with budgets and management of IT professionals both on my hospital staff and working for an independent company where we became experts in delivering compliant services, so that not only were we making sure that our clients were compliant, that everything we did helped them build the evidence of compliance if they were ever audited. In terms of the risk analysis that is core measure 15 in meaningful use, and a lot of people thought is something that's new, actually goes back to when the HIPAA security rule was announced in 2003 and then implemented in 2005. And it's been confusing for some folks because the Electronic Health Records Incentive Program for the government doesn't say much about HIPAA, but in one of their guidance documents, it says that the measure is to conduct or review a security risk analysis in accordance with the requirements under 45 CFR 164.308A1. And that's a lot of technical lingo for the Code of Federal Regulations, and if you go and look up that section of the Code of Federal Regulations, you will see that 45 CFR 164.308 is the HIPAA security rule. So basically what Meaningful Use did is they kind of dusted off a requirement that goes back to 2005, 7 years ago, and is now a base requirement that people really had not done in the past, or if they did it, maybe it was 7 years old and not considered current. So the big difference between a risk analysis then and a risk analysis now as part of Meaningful Use is that back then it was to protect patient data in almost any form electronically, but now it's really tied to the EHR programs, the Electronic Medical Records or Health Records programs, because through the incentive program it's obvious that everyone has implemented a certified EHR program. So there's now a focus on this, although it's not an exclusive focus, because when we audit physicians' practices and hospitals and other healthcare organizations, we find that there's protected information that is outside of the EMR system. Everything that relates to a patient, and particularly if you've only implemented EHR recently, you may have older systems where you wrote letters to insurance companies to help patients appeal denials, or you sent letters to employers that may have talked about the patient's diagnosis. They can't come to work because of X, and if that information is stored electronically, that's also protected information. So any combination of something that's identifiable, like a patient's name or even social security number, combined with treatment or diagnosis information, is protected, even though it may not reside locally in the EMR system.
Thanks, Mike. You know, I think one of the issues is that a lot of the terms, as you mentioned in that particular document, and a lot of the delivery of information that's going out specifically to clinicians is pretty confusing. And you know, one of the primary questions that we've had from our site visitors from a security standpoint is relevant to the core measurement 15. And I wonder if you could talk about that a little bit and referencing it as it relates to the security risk analysis. Is this a new requirement in healthcare?
Well, no, as I said, it goes back 7 years, but the problem with HIPAA is that HIPAA was developed to address all healthcare organizations, both providers and payers, no matter what your size or location or specialty. So the problem with HIPAA is that it's been pretty vague, and the other thing is that it hasn't really been enforced until recently. There's a joke that says, has anybody ever seen a HIPAA policeman? And no, that really hasn't happened. There have been some breaches. They've been large, and because it's been the federal government exclusively enforcing HIPAA for many years, it took a pretty high threshold of a data breach before it was investigated and pursued. But in the HITECH Act of 2009, which is the law that funded the Electronic Health Records Incentive Program, there were some other sections of that law that didn't get as much publicity. The data breach laws were changed. Local or state attorneys general were given the authority to enforce HIPAA. So it doesn't sound like much, but that multiplied by 50 the amount of enforcement agencies across the country. So a state attorney general can now enforce the civil violations of HIPAA, which is where most of the data breaches fall. And encryption was allowed not as a requirement of HIPAA, but as I call it, the get out of jail free card. If a device is encrypted and it's lost, it's not reportable. So all these things tie together, but the most important thing that changed with the HITECH Act that is not been as publicized as much is that the federal government funded enforcement and changed the enforcement agency. It used to be CMS, Centers for Medicare and Medicaid Services. There was an internal audit done by the Department of Health and Human Services that said that CMS was not enforcing HIPAA at the level that they should have. So when the HITECH Act came out, a different department, the Office for Civil Rights, was given the authority to enforce the HIPAA security rule, and they hired a fellow named Leon Rodriguez, who's a former federal prosecutor, to run the office, and they funded audits and a staff for him, and said that his office gets to keep the funding, gets to keep the penalties that they assess for violations. So now you've got enforcement being funded, you've got an experienced federal prosecutor running the agency, and they've got a financial incentive. They get to keep the money, and a general incentive, which is that they have to show that they're enforcing HIPAA because they know that the Office for, or the Inspector General is keeping an eye on them because it wasn't enforced in the past. All that resulted in a lot more enforcement activity in 2012. And fines were assessed to small practices. A 5-doctor practice in Phoenix, Arizona, paid $100,000 for having patient data on a public calendar on the internet, and they were sending patient data through an unencrypted email system, an online webmail system. The State of Alaska Health Department was penalized $1.7 million when a technician backed up a server onto a hard drive and took the hard drive off-site, which is what you're supposed to do because you don't want to leave your backup in the same physical location as your original data just in case the building burns down. And that drive was stolen. They were assessed a fine $1.7 million. A hospital in Massachusetts had a doctor go to a conference, and he had patient data for a clinical trial he was working on, and his laptop was stolen. They were fined $1.5 million. And just last week, a penalty was announced, which shocked everyone. A small hospice in North Idaho was settled with the federal government for a $50,000 penalty, and they had a lot of other additional costs to solve their underlying problems for having a laptop stolen, and that was a vendor, a business partner of theirs. And what surprised people, not just that it was a fairly small organization, the $50,000 fine was because 441 patient records were lost on that laptop. So all of these penalties could have been avoided, and these are the things that we find in a risk analysis, that if the HIPAA administrative, physical, and technical safeguards were properly documented, the policies were enforced, the training was done, and the technical features were put on the systems, such as the laptop and the hard drive that were lost, there wouldn't be a penalty, and there's likely wouldn't even be a breach. In other words, the laptop may not have been stolen if physical security practices had been in place, and if it was stolen, if the data had been encrypted because of the HITECH Act data breach law modifications, the loss would not have been reportable.
Mike, while you were giving us your summary in that last question, I just want to let everybody know to feel free to type your questions throughout the presentation portion of the session today, and we'll address as many of these questions as possible within the hour. Somebody did ask you to repeat the name of the federal office again from your last paragraph.
Okay, under the U.S. Department of Health and Human Services, the acronym is OCR, which is the Office for Civil Rights, which is the agency or the department within the agency responsible for enforcing HIPAA. As with many things in healthcare and the government, there are acronyms. So when we talk about meaningful use, we talk about ONC, the Office of the National Coordinator. We talk about CMS, the Centers for Medicare and Medicaid Services. We talk about HHS, which is the overseeing the agency, which is the U.S. Department of Health and Human Services. So I apologize for using acronyms and things, but unfortunately it's the language that we have to talk about when we're dealing with compliance.
Right, and so in cases where the acronyms are unclear, I'll just potentially ask you to repeat. The next question we had is from our site visitors that we compiled this particular webinar for, is why you feel that HIPAA compliance is tied so closely to the risk analysis that has been required.
Well, other than the obvious fact that the risk analysis that they refer to in meaningful use is actually a requirement of HIPAA, what the risk analysis is intended to do is to identify vulnerabilities that may occur in the whole environment of protecting patient data. So that environment includes the physical aspect, the actual devices themselves, the laptops and the tablets that people may carry, desktop computers, file servers, all the networking infrastructure. So we've got that part of it, but one of the biggest risks is with people and the way that they do things and how they behave. So a very simple example of tying policies and procedures together with technology would be that a lot of systems have very tight and complicated password systems built into them, so that users have to authenticate, and sometimes it's multi-factor authentication where they might have to type a password but also swipe their fingerprint or a card that they carry in order to get into a system. And when it comes to single-factor authentication like a password, you can build all the technology to the point where it's doing the right thing, but the minute a user writes their name, their login name, and a password on a Post-it note and sticks it on their monitor, that's where the human factor in the equation takes hold and creates this breach. So what we do with a risk assessment is we look at several things. We look at risks themselves. So from a risk analysis standpoint at the highest level, we would look at things like if you're on the East Coast, we would look at the risks of hurricanes and the things that are associated with them. Used to be a lot of times hurricanes were focused on Florida and North Carolina, and as we've seen in the last couple of years, some of the greatest damage has been done north of there in Long Island and Connecticut and New Jersey. So we look at the risks that can occur that are specific to a geography, earthquakes in California and the things that you would normally associate with those things, anything that could interrupt the practice from operating. Then we look at the human risks, and the human risks sometimes get down to training. People don't realize what they should be doing in best, for instance, IT practices, where if they get an email that says you haven't paid all of your federal taxes, click here, and it comes from the IRS, and it says click here on irs.gov to find out how much you owe. And when you click on that link, it takes you someplace completely out that's not the IRS, and it can put an infection or a virus or malware on your computer that can allow somebody else to log in and see what your password is, or in some cases get into a bank account. So what we're trying to do is educate the users to be wary and to follow best practices for IT, even generic things that would be done in a regular office, as well as understand some of the rules about protecting patient data. One of the scary things when I was the CIO for a hospital was that we had to give all the practitioners access to every patient record. We couldn't say that a nurse was working on the second floor, wing 2B, and not have access to patients on 2A, because if someone called in sick, that nurse might have to float over to the other wing and take care of those patients. And obviously, we had no time in the IT department to get a call and change their access levels. But one of the rules of HIPAA is that you should only access patient data for patients that you're treating. So when it comes to setting up an EMR system, and this will vary based on the size of the practice and how people are assigned responsibilities, people may be assigned in the EHR system only to be able to see things like schedules and payment information, but in other practices, a receptionist may be able to see lab results just to make sure that the labs came back before a patient visit. So there are a lot of rules and things that we have to look at based on HIPAA. We tie them to the risk analysis, and what we're trying to do is, since we can't reduce a lot of the threats, I can't stop a hurricane from coming up the East Coast, we can help mitigate and reduce the vulnerabilities by either having data stored in an off-site location or have things like battery backups on the servers and remote access if people can't get to the office so that they can still get to their data. So the risk analysis is huge in terms of being able to treat patients now that the health records have gone electronic and you no longer have paper charts. You're tied to either a local network connection or an internet connection.
So in terms of the information itself, can you give us a little more detail about what information is protected? Are we assuming that all information that is stored in the EMR is protected?
Well, I think there's a different answer to the second question. I think all the information in the EMR is protected, but as I said earlier, not all the information that is protected is in the EMR. So again, any document, electronic file, which could be a letter, it could be a Word, Microsoft Word, or a word processing document, it could be a spreadsheet, it could be a database file from an old system. Anything that has the patient name, an identifier, as well as any treatment or diagnosis information is protected. So it could be something that is in an email, and there are no rules particularly saying you can't email documents, but they have to be in secured systems. So there are webmail systems which are not secured. Text messaging is not a secure way to communicate patient information. So if you go back to the original premise of HIPAA, and not the security rule, but the privacy rule, it's all information is protected, all identifiable patient information is protected, and that includes the written word. So in the old days it was paper charts. It includes electronic data, which would be anything in an electronic system, even though it's not part of an EHR system, and anything verbal, which is why doctors and practitioners know not to carry on conversations about patients within the earshot of other patients. So all identifiable patient information is protected. And what we find is that organizations, healthcare organizations, will tell us everything's in the EMR system, and either as we ask more questions or if we ask to audit some devices, we will, in almost every case, in fact, I think every case that we've ever done, we found electronic data that is not incorporated in the EMR system.
Can you also address how the risk analysis is generally executed? Who are the clinicians hiring to do these risk analysis? What's the structure and what should be included in that risk analysis, from a kind of a nuts and bolts standpoint?
Wendy, that's a great question because there are no specific standards in HIPAA for the risk analysis. They tell you to do one. There's no specific standard in Core Measurement 15. They tell you to do one, and they refer back to HIPAA, where I already said they didn't tell you how to do it. But there is guidance. There's really good guidance out there in terms of how to do a risk analysis. The Office for Civil Rights has some guidance from the HIPAA standpoint on how to do a risk analysis. The Office of the National Coordinator has some documents, and I believe these are going to be posted to the EMR-approved website. But when it comes to compliance with these regulations, there's an organization called NIST, N-I-S-T. It's the National Institute for Standards and Technology. And basically, this is the organization that writes the how-to guides for federal agencies to comply with the regulations that they have to follow. So I'm not sure how many people are on the call working for federal agencies, but there are a lot of federal agencies that deal with health care. For instance, the Veterans Administration and other federal agencies that have health care facilities. So NIST has some publications. NIST 800-30 is one of them in terms of how to do a risk analysis and comply with HIPAA. So basically, if HIPAA says you have to do something, and NIST has some guidance for that, if you follow the NIST guidance, you will pass a HIPAA audit because NIST is essentially the playbook that the federal government uses to comply with these things. Now, that said, you have to be able to understand and interpret what they're saying and what you're seeing. So when we go into an organization and we interview people and then we look at technology, and a lot of this is checking things like firewalls to make sure that perimeter protection for a network is in place. It's making sure that servers are properly protected both physically and technically. And it's also making sure that what we call endpoint devices, we used to say computers, but now there's such a difference between endpoint devices. You've got desktop computers that are plugged into the wall and hardwired to a network. You've got laptops that people carry. And now you've got smartphones and tablets. So we don't distinguish between them. We basically say that all endpoint devices have to be protected against malware. So there are a lot of different parts and pieces to this. And my experience is that if you're a healthcare professional, unless you really understand security and IT, you may not do an adequate job to do a risk analysis. And the reason I'm saying that is that what we found is that once it stands up to the scrutiny of an audit, you really need to have the view of a specialist the same way that you would refer a patient to a specialist when something, for a diagnosis and treatment plan. It's the same kind of thing with this. So there is guidance, but the biggest thing that you have to make sure of is that you can understand what the guidance is telling you, both on the diagnostic standpoint and the treatment plan.
So moving on to some of the scarier parts of this conversation, what would you can you give us a little background on the actual audit process? What is a meaningful use audit, and how are the practices identified by the auditors? Do you have information about that?
Well, a meaningful use audit is, I think, similar to something like an IRS audit. And what could trigger an IRS audit would be some anomaly in the reporting. So if you were in a business or you earned a certain amount of money and you claimed greater deductions than most other people, then there may be some formulas that will trigger an audit. There also would be perhaps a history if you had issues with your, keep in mind that this is part of the Medicare program, so if there have been any issues with Medicare payments or claims, that may trigger it, or it may simply be random. And that's a question I've asked when I found out about practices being audited. Do they know what triggered it? And unfortunately, the answer has been no in most cases. That one practice that I'm aware of that we talked to, I talked to an IT provider last week trying to help a practice remediate some problems, and they were being audited. I asked what triggered the audit, and they simply didn't know, other than there had been some dispute with some Medicaid payments a couple of years ago, and they may have been on a short list to audit. But the real answer is we don't know exactly what will trigger an audit.
And, you know, given that the result of those audits obviously are penalties in some cases, and, you know, folks, I assume, are attending this webinar on some level to perhaps understand how best to avoid that. Explain to us a little bit about, you know, what can be considered a breach for PHI security, and what you've already given us a little idea of what the potential penalties are, but, you know, maybe talk a little bit about how those breaches relate to those penalties.
Well, there are the obvious breaches, and then there are the ones that I think are breaches that people sometimes are surprised that they are actually committing without knowing it. So the obvious ones would be, for instance, out in Las Vegas, there was an admissions officer at a hospital who was selling patient face sheets. These patients came in from car accidents and work accidents and things. This admissions person was selling patient face sheets to attorneys, to the personal injury attorneys. That's as obvious and as blatant a breach. And by the way, that carries criminal penalties, because a HIPAA data breach that's considered for personal gain or for harm is a criminal violation, not just a civil violation. But anytime patient data, that identifiable patient data, ends up in the hands of someone that it doesn't belong to, in other words, who's not part of their treatment program, it's a breach. So if you're a doctor working for a covered entity, you certainly have, you're entitled to get the patient information, but if that data is shared with anyone else, even another doctor who's not involved in the care or treatment of the patient, that's a breach. There are other breaches. So now we have to talk about business associates. So a business associate would be a business partner of a covered entity. So a covered entity is any organization, typically a hospital or doctor's office, that's involved in the care of patients and bills electronically. Then you have the payers. So the insurance companies and Medicare are payers. They're obviously covered by the HIPAA regulations. Sometimes payers are surprised to find out that they're payers. And obviously an insurance company, a health insurance company paying for health care is obvious, but a corporation or a school district that self-funds its insurance program is also a payer. So we've had people that are not in the healthcare business become very surprised when they find out that they have to comply with HIPAA. So anytime the data is shared with someone that's not a covered entity, you should have a business associates agreement. This goes back to the fundamental security rule with HIPAA. And a business associate is anyone who's not a covered entity, who has access to patient data and is likely to see it. There are a few gray areas, but the obvious business associates would be the EMR company, because they're very likely to, it's their support of the practice, have to see patient data, either have the data files or log in and look at someone's screen, or have a trainer on site working with live patient data. So you'd need a business associate agreement with them. An IT company that maybe offers you help desk services or has technicians and engineers coming in to work on your systems, they touch the data. A shredding company, if you have one of the locked trash cans in your office where you put lab reports and copies of patient records that you're discarding, they're literally touching it. They unlock that container, take the patient records, sometimes out to the parking lot if they have a truck, and shred them there. They're in possession of the patient records from the time they leave the office until the time everything is shredded and unreadable. You've got other organizations that you wouldn't necessarily think of. So an accounting firm that is auditing the records at a medical facility will look at patient information and track the financial parts of the transaction, where the insurance companies bill, that the payments come in, how are they tracked within the hospitals or the practice's accounting system. So they're looking at patient data. You would never think that an accountant really would have a reason to see patient data, but they do, you need a business associate agreement with them. And then if there's ever a legal issue where you have to defend a lawsuit, or if you're going after someone for payment and you're providing that patient information to an attorney, now the attorney has to be a business associate and sign a business associate's agreement. So there's a lot of focus now on business associates because a lot of the data breaches occur by business associates. There was just one with this past week where 68,000 patient records were breached by a company that offers like the pharmacy on a cart type service. It has a computer in it, it dispenses meds, the records are kept. A technician downloaded the information from multiple practices, multiple facilities actually, onto a single laptop, and it was stolen. That's 68,000 records. Now, HIPAA and the people that enforce it, or the people that enforce HIPAA, have recognized this. So part of the High-Tech Act of 2009 that funded the medical records program also said that business associates now have to comply with HIPAA, and they can be penalized directly instead of just having the healthcare organization to whom they provide service paying fines. But what we're seeing is a big focus on making sure that business associate agreements are in place and that the business associates understand HIPAA and comply, because that's an area that we find with a lot of in the risk analysis, the core measurement 15 risk analysis, it's a very weak area when you're talking not just about the medical provider, but the organizations that they partner with. The penalties, as I've said, in the last year have ranged from a minimum of $50,000 for the lost laptop in northern Idaho to $1.7 million in the state of Alaska for a lost hard drive.
Wow. One of the more confusing aspects of this set of regulations is relevant to the recent deadlines that folks have been discussing relative to compliance. And can you give us a little framework around some of those deadlines and dates, and could help us clear that up a little bit?
I'll do my best. The first deadline that we need to talk about is April 20th of 2005, because that's when the HIPAA security rule kicked in that said that you needed to do a risk analysis. So that needs to be in context here, because basically core measurement 15 for meaningful use picked up that rule and said you have to do it as part of your attestation, and specifically they want the meaningful use risk analysis, or the security risk analysis, done during the reporting period. So you need to make sure that your risk analysis is current, and this has been an issue with HIPAA. HIPAA, which relates to the meaningful use risk analysis, never said how often. There's nothing specific about how often a risk analysis needs to be reviewed or completely redone. What they've said is you need to have one. It needs to be updated as there are significant changes to your environment. So for instance, if you're a hospital and you've acquired new medical clinics that you now have to make sure are covered, that added some risk to your organization, you should update your risk analysis. If you've gone from not having an electronic medical record system to having one, that's significant. If you've opened a new office someplace, that's significant. So basically a risk analysis needs to be part of every major decision, and it doesn't say you have to do one from scratch every year, but with the meaningful use risk analysis, one of the things you could do is if you have one from last year, you could show that you reviewed it this year, and even if there were no changes, just documenting the review process. So the end of the 2012 reporting period was the end of 2012, December 31st, 2012. So the risk analysis for the reporting periods in 2012 expired at the end of the year. The reporting period expired at the end of the year, so you had to have your risk analysis done and mitigate the problems that were found within the risk analysis. So if you attested back in 2012 that your risk analysis was done, and you also attested that you mitigated the problems that it found, And for those people that waited up until the end of the year, so their reporting period ended December 31st, you have until the end of February actually to attest.
Wow. So before we jump ahead, talk about the February deadline a little bit. What is encompassed in that February rule?
Well, the February deadline is just that if you're going to attest to having achieved meaningful use in 2012, your last date to do it is the end of February. Now, again, you're attesting to what occurred in 2012, so you're already partway into the first reporting period for 2013.
Wow, okay. And so with that in mind, with the February 12th, if you've made the statement that you've taken these steps by the end of 2012, but then you've got to take an extra step before the end of February, what exactly is that? How are they filing that? Where are they filing that?
Well, the meaningful use attestation is filed with the Office of the National Coordinator, and there's a ton of instruction out there, and many of the, I think all of the electronic medical records software companies are providing some guidance on that. But what I've seen with the EMR systems is that in most cases, they're working through Core Measure 14 and saying you need to do Core Measure 15 and let us know it was done. So there's no guidance that I've seen really coming on the meaningful use risk assessment or services from the electronic medical records companies. I may be mistaken on that in terms of some of the services that may be offered with the purchase of an EMR system, but essentially the ones that I've talked to recently have been told to do that on their own. So one of the questions that's come up regarding the deadlines is from practices that attested in 2012 and now realize maybe they should have looked at the Core Measure 15 risk analysis harder. Maybe they didn't do a good one. There's a document called the Risk Analysis Myths and Facts that the federal government's provided, and one of them says, is a checklist okay for a risk analysis? And their answer is no. And what's important is that I've seen a lot of organizations who say, well, I used a risk analysis checklist and submitted that or considered that to be my risk analysis, and now I'm seeing guidance from the government agency that's enforcing this rule saying that's not acceptable. So it says really you've attested to something that may not stand up to scrutiny. I'm not going to say you lied or you were mistaken. It's just your attestation may not stand up to scrutiny when it comes to this. So this is the area that we don't know what's going to happen when it comes to the enforcement and the auditing. My assumption, based on the way I've seen the federal government work in the past, is that they're not looking for every little reason not to provide the incentive funding. What they're looking for is both intent to comply and the actual actions taken to comply. So if the risk analysis is something that you're not comfortable with, it's better to do it now, even after the enforcement or after the reporting period. It's better to do it, and even if you have to claim that it was done late, you're showing intent to comply, as opposed to saying, well, I know that I missed it in 2012. I still haven't done it, and I hope you'll give me the money. So the choices are not good. First of all, you could withdraw your application and give the money back. But the other thing is that I really think, as much as we hear on television and on the news about the unreasonableness of the federal government and how crazy it is to deal with them, that there is some reasonableness that's being applied to this, and that if you've attested in 2012 and you really haven't done everything to comply in 2012, but you do it quickly in 2013, you've got a much greater chance of passing an audit and meeting their requirements than if you just let it go.
And I think that's very good advice, obviously. And as our last presentation question, before we start to read through the questions that have come in throughout this last 45 minutes or so, can you give us a little thought process around how a medical site can protect itself against unintended breaches? I will just offer up a recent experience. the CEO of EMRapproved, was on an airplane, and I think he communicated this to you. And he was able to see through the crack in the seats of the airplane somebody's laptop with PHI, with an EMR opened up on that laptop, and so that information was readily visible to him through that crack. Is that a breach?
That's a breach.
Okay, and so how what advice do you give to the clinical community to protect itself against unintended breaches?
Well, there are several answers to this, but in that case, and I think in most cases, it gets down to policies, procedures, and end user education. So if and I believe this was a doctor who was looking at the EMR system while traveling, and if the doctor was properly trained in terms of what the HIPAA regulations are and what constitutes a breach, then you need to have what I call situational awareness, which is kind of to be aware of your surroundings. And in the case of an airline seat, you've got the person next to you who could see something pretty easily. Now, there are devices, there are screen covers that you can put on that essentially put a lens over the screen so that unless you're sitting straight on with the device, that you can't read what's on the screen. But even in that case, I think the person in the seat behind was probably positioned well enough that even if one of those screen covers had been used. So the bottom line answer is don't do it. And there's not a technical way to stop that. When you turn your computer on and you've got internet on an airplane, you're not going to get a lot of warnings that, are you sure you should be looking at this right now? And one of the things that we did with reminders at the hospital where I was the CIO is we did have messages pop up that said, are you sure you're looking at this in a secure location, et cetera, et cetera. And this is a classic example of user education and policy. So a policy would say, don't do this. No patient information is to be accessed on any device outside of the office, even within the office, where someone not authorized to see it may see it. Unfortunately, now it's easier than ever to create a breach because the systems, the EHR systems, are now offering apps for tablets and smartphones and things like that. So how do you protect yourself there? Again, you have to have some situational awareness, but there are some technical tools such as encryption where the data can be protected. In many cases, the data never actually transfers to the device. The device where you log in, you become a remote access user. So there's no data on that device, but now you have a window into the EHR system. And again, you have to make sure that you're doing this in a secure environment. One of the obvious things that we've dealt with physicians who work from home is to have a separate secure system that is not the family computer to access patient data, where other people may literally be physically accessing the device or doing things like games and going to websites that could infect that system. And then you've got training at different levels. So there's HIPAA training, and a practice manager or a compliance officer for an organization. And HIPAA requires that a compliance officer be named in every covered entity. So every doctor's office or every healthcare professional or paying agency or billing agency, by law, by the HIPAA security rule that went into effect in 2005, has to have an identified security officer. So the people that have taken that responsibility on should really understand HIPAA and get training in HIPAA. There's also a requirement for security awareness and training for your end user audience. So that type of training is different. There's some information about HIPAA and protecting patient data, but also best practices in terms of not clicking on links and emails that came from people you don't know and so forth, and also policy rules that say our organization has a policy against, and you may put technical tools in also to prevent these things, such as downloading data onto a thumb drive. But even if people were able to do it, and again going back to the example of the doctor looking at patient information on the plane. If the doctor has a policy for their own practice or the practice they're working for that says you just will not do that, that can be not only enforced in terms of being able to prevent it from happening to start with, it can be audited on the back end, and reports could be generated that, you know, during the time that you were flying, you were accessing patient records, and that's against our policy and procedure. The reason you want to do that internally is to make sure the problem doesn't happen again, because the alternative would be having the same audit done during an investigation where now it's proven and there's an attached fine.
Well, thank you, Mike. That was a lot of detail. We can always count on Mike to have as much information as possible given any question on this topic. So hopefully you all have enjoyed the presentation so far. You know, as Mike was mentioning a moment ago, there are some requirements around training. So, you know, one of the ways to mitigate or to help protect against breaches is to basically understand the regulations a little better. I mean, if you do understand what those regulations are and have some detail on that, obviously you're less likely to certainly unintentionally create a breach in your environment. Right before we jump to this rather large list of questions, and please let me answer one of the questions that was repeated several times, which is, will these slides and this presentation be available after this session? And the answer to that is yes. We do record these sessions. We do post them to our YouTube page. We will send a follow-up email to you if you have registered for this event, and we will send you a link to that YouTube presentation, a copy of the PDF slides, and some additional links and information that might be helpful to you on this topic. So just wanted to get that answer out of the way since it was submitted as a question several times. And then on this sort of the tail end of this slide, I noticed some of the questions are relevant to who is a security specialist? How do you know that you're working with a security specialist? How do you identify a security specialist? Can you talk a little bit about that?
Sure. Wendy, that's a great question, because there are, as with anything, there are a lot of different ways to measure experience and competence. And when it comes to a security specialist, I would equate it to how do you identify a medical specialist too. So you've got generalists, and there are a lot of generalists in technology who dabble in security, but they're not security specialists. You've got specialists in healthcare. And in healthcare, they've gotten specific education into a specialty. And you can pick any specialty, whether it's cardiac or thoracic or pulmonary, rheumatology, whatever. They've gotten specific education in those areas, and they are certified or board certified. They've passed some tests and have to maintain continuing education credits in order to maintain their specialist certification or their medical license in that case. So in healthcare and in IT, we have similar types of processes. So I am certified. It's interesting that the risk analysis is not unique to healthcare. A risk analysis is actually the first section of a business continuity and disaster recovery plan, where we go to a site and we analyze what are the risks to that facility, the same way we start out with a medical office. Are you in a hurricane area or a tornado zone? Do you handle hazardous materials? Are you next to a railroad tracks where hazardous materials are transported every day, et cetera, et cetera? So I'm certified in that through the Disaster Recovery Institute, but I'm also certified in HIPAA and in general security compliance. And my certifications for those came through the HIPAA Academy, and now we've written a HIPAA certification course for EMRapproved. So what you're looking for when it comes to security specialist, we're really talking about an IT security specialist, is that you want someone that's got the experience in technology, but you want to know what their general skills are in terms of technology and securing IT systems. And then what really becomes the challenge is making sure that they are compliance specialists as well, both to help you comply with your compliance regulations, in this case HIPAA and meaningful use, but also so that they're delivering services properly, so that they don't take a laptop in for service or replace a hard drive and throw the old one away, and then you find out there's 50,000 patient records on that, and that's an inadvertent data breach.
Well, thank you very much, Mike, for all of that information. I am going to now...
Thanks for having me, Wendy. I appreciate it.
And we're going to take the last 10 minutes of this session to read through some of the questions from our audience on this webinar. We have quite a few. We will get to as many as we can in the last 10 or 15 minutes here. For those of you whose question is not answered for some reason, either it came in too late or exceeded our time, we do have a recording of all of these questions, and we'll reply to these questions via email in your follow-up email after the session. So know that your question will be answered. We're going to try to do as many as we can over the next 10 minutes, and we're going to start with the one that came in really right at the beginning of the session, which is relevant to a radiologist. So the question is, the radiologists in this practice work, or rather work within a health system, and although the docs have purchased their own EMR, it's that EMR is fed, or EHR is fed, patient information from outside sources that are controlled by that health system. Since those docs don't have control over that health system, how can they address that with regards to the meaningful use requirements?
Wendy, it's a great question, and it goes back to one of the early audits that I did when I was starting with the HIPAA compliance as a business service. And that was, I was contacted by a radiology group, and they asked me to assess their practice. And originally our questions were, how many offices do you have and how many physicians do you employ? And that gave us an idea of the scale. Their answer was we had one office. Well, it turned out it was a billing office because their radiologist never went there. They worked out of, I think it was 6 different hospitals. Well, the challenge was that HIPAA still required the radiology practice to comply with the regulations, although they were basically on 6 different networks owned by 6 other organizations. And what we had to do was work with those organizations as if they were like the landlords, if you will, to the radiologists who were working there, and we developed reporting that showed what the organizations were doing, and then we also had to track separately what the radiology group was doing, for instance, to train its employees and comply with the policies and procedures that all practices have to have. So my answer to the question is that from an administrative standpoint, the radiology practice has to have all the policies and procedures in place, just like any other covered entity. They need to be able to stand up to the scrutiny of an audit. So I add not just policies and procedures, but a separate area called evidence of compliance. You want to have things like sign-in sheets for training sessions, so you're not telling people, yes, we did one. You're saying, yes, we did one, and here are the signatures of the people that attended on that date. That's evidence of compliance. Then the physical and technical safeguards in HIPAA typically would be done. Now, we had to do the radiologist billing office because that's where their patient data and where their bills came from. But we also had to work with the IT departments at the facilities where the radiologists were located so that we understood the physical and technical aspects of their facility, because that's where the some of the patient data was.
The next question is, what are some of the audit protocols that you know of that are being missed during standard risk analysis processes?
Well, I'm not sure. The audit protocols that are being missed, I guess the greatest audit protocol that's probably being missed is not a specific question on a list, but understanding the question and the context that an auditor is going to look for. So there are lots of audit questions available. In fact, last year the High Tech Act funded audits of 110 medical facilities, which is very small compared to the huge population of medical organizations, healthcare organizations, and the criteria for those audits was published. So we can put a link to that on the EMRapproved website, but my biggest challenge when I'm dealing with practices and with people that are answering questions is that sometimes I have to ask the question 2 or 3 different ways or explain a context of a question, because it's not just the answer that they're offering, it's that I may see things and observe actual protocols that are being followed that I don't think follow some of the guidance, and they're saying, yes, we're doing that and it's the right way.
There are several questions relevant to email. So I'm guessing you get those quite a bit in your business. A couple of them, I'll try to conjoin these if I can. If their internal email, via Outlook for instance, is not encrypted, but it's sent through a secure network, is that okay?
Well, I guess part of that depends, and the reason I'm saying it depends is how do you define network? Now, not so much as Outlook, and Outlook uses a server on the back end called Exchange. So part of it is where is that server located? How is it protected? So you've got a physical aspect to this, and then when you're dealing with quote-unquote internal, the problem with internal is that networks are no longer the way they used to be when they first came out, which is having computers hardwired into physical networks in a single location. But now networks are pretty virtual, both in the idea that people can connect from remote locations. They can connect wirelessly, so you don't have to have the hardwired connection into the wall. Even in a facility, you've got an issue with a wireless network transmitting patient data, because that wireless network has to be properly secured. So it's not just a question of Outlook being secured, or you could use an Apple system or some other system. It's not, that isn't the only question. It's how are you securing your network. There's no specific provision against emailing patient information internally, but you do have to be very careful that you look at the entire environment and remember how easy it is to misaddress a message, which may cause an inadvertent data breach, or to send something outside of your organization just by a keystroke. So there are systems that are available that are secure systems where that data can be sent, and it can be done where it's either manual, where you say that this email should be encrypted, or there are some systems that have intelligence built into them that if they see that there's patient data either in the email or in the attachment, it will automatically encrypt it.
That's good advice. If there are a couple more email questions that I thought were pretty good. One is if the patient information is sent via encrypted email from their site out, and that site replies a response, but it's not encrypted from their end, who's responsible for that?
In theory, it's the sender. But I wouldn't want to be the receiver of that, because now you've got the challenge that if you receive it unencrypted, you should, by law, report that as a data breach. Okay. That's a pretty ugly situation that can be avoided. One of the things that's not asked here, that we had the question about Outlook, but with a lot of the practices that I work with is they're saying that now they're doing their emailing within the EHR system to each other, so it avoids having to go outside and have to deal with an unsecured network. You need to have access into the EHR system, and once you log in, you can see your messages and reply to them. So that's a completely secure environment that allows that.
How does a provider know if their email system has encryption? So do the big email services like Gmail and Yahoo and all those Hotmail, are those encrypted?
Not only aren't they encrypted, but they're very easy to break, and you don't have control of them, and they will not sign business associate agreements. Hotmail, Gmail, any of the web-based mail systems are totally inappropriate to use for sending any protected patient data. That doesn't even have to be like a copy of a lab report. It can be as simple as a one-sentence message that has a patient's name and their diagnosis or treatment information.
Will passwords that meet specific requirements mitigate fines if laptops with records are stolen? That's a good question.
The answer is no, because the word that wasn't in that question is if the laptop is encrypted. So simply putting a password on a device does not encrypt the data. If someone can hack the password or log in or bypass the security that the password protect or the security of the system itself, for instance, a Windows computer, that system, once they get in there, they can read the data. With encryption, even if they can log into the system, they should not be able to get to the data in a readable form. So let's go back to the HITECH Act. It doesn't say passwords, it says encryption. So unless you specifically have paid for encryption, and that can be done either as an add-on product. There are certain companies that offer software programs that can encrypt data, or you can buy computers now that have self-encrypting hard drives. So some of the major manufacturers of laptops, for instance, have models that have self-encrypting hard drives. So if you buy those, number one, you need to be knowledgeable enough to turn on the encryption, and you have to make sure that it's consistently used, and you should document what you've done in the type of encryption program, so then if the laptop is stolen, you don't have to report it.
Very good. We really only have time for maybe one or two more questions. We've kind of hit the end of our hour here. And I will let everybody who is still on the webinar know that we do have quite a few questions in this list. I would say far more than we could possibly answer even with another hour-long session. So as an answer to your questions initially, I will say that Mike is here in our offices with us for the next couple of days, and that between Mike and some of my security skilled staff here at EMRapproved, I think we probably can respond to and reply to a good number of these questions in our email replies to you. So don't fret if we didn't get to your question today. I will pull a couple more of these out, but know that we will respond to them in your email reply sometime within the next day or two. I see one question that was repeated several times that I actually can answer, which is, do you have a good sample of a business associate agreement for healthcare? And my answer to that is that through the HIPAA certification program that was authored by Mike Semel, the gentleman who's been presenting for you today, we do include in that certification program a business associate agreement sample. We do recommend that every person, we actually state it right on that agreement, we do recommend that everybody take that to their attorney and make sure that it meets their internal requirements as well as any requirements that might be specifically related to their business and their practice. However, it does give you a good baseline for a business associate agreement. And on the topic of business associates, there was a very good question here for a couple of folks that said, do they need to have a business associate agreement, for instance, with all the pharmacies that they send electronic faxed or verbal prescriptions to, and are business associates held liable to the same level for that the covered entity is carried to as well?
Okay, those are two different questions. In the cases that I know of, pharmacies are covered entities, so you don't need to have separate business associate agreements with the pharmacies. But the last part of the question about do business associates have to meet the same level of requirements, there's kind of two answers to that. In the past, the answer has definitely been no, because the business associate was only governed by the business associate agreement. So it's basically a contract between two businesses. So if a business associate caused a data breach, they were in violation of their contract to their client, but they weren't in violation of federal law. As crazy as that sounds, that's what's been going on from 2005 until now. This year, 2013, even though the law went into effect, it said that business associates have to comply with HIPAA. The way that the federal government works is that even though the law was passed, there's now some agency rules that are going through that came from Health and Human Services. They're going through the Office of Management and Budget. It's got a very confusing name. It's called the HIPAA Omnibus Package. And as soon as that comes back to Health and Human Services for publication, business associates who are still governed by those contracts with their covered entities are then going to have to make themselves compliant in terms of training and all the administrative rules, policies, and procedures, for instance, that the covered entities do, and then they will be punishable by the federal government. And Leon Rodriguez, who's the head of the Office for Civil Rights, recently said in an interview that they're going to publish the rules and then give business associates 6 months to comply before they start enforcing them.
Wow. Well, thank you again, Mike, for giving us so much of your time today. And thank all of you who are still with us for attending today's webinar on the topic of HIPAA security and risk analysis. We hope that you'll join us for our February Learning Lunch session, which will be announced sometime in the next week or so. And we will, and just to repeat, we will be sending out an email follow-up with some helpful links, some additional information. We will answer as many questions as we possibly can from your question list that came in throughout the session. And you know, as an important note, one of the reasons that EMRapproved engaged in this particular webinar session this month was because site visitors to the EMRapproved.com website have been addressing a lot of HIPAA questions, in particular recently, because of a lot of the news reporting and because of the deadlines that are impending at the moment. We do, through our EMRapproved formedtraining.com website and at EMRapproved under the training and education area, have some additional information about HIPAA certification and training programs that might be helpful to you, that also include things like business associate agreements and additional helpful links and information. We do offer HIPAA security services from skilled security consultants that might be able to help practices of varying sizes and medical site locations of varying sizes with that, HIPAA security service that several people have asked about in their question section as well. Again, thank you very much for joining us today for the EMRapproved.com Learning Lunch session, and we hope to see you again next time. Thanks, Mike.
Thanks, Wendy.